Good morning, everybody. Welcome back. I'm so happy to meet you again in this very important project, really. Today, we'll talk about the role of advanced critical care ultrasound in acute dyspnea. Really, it is a magic. And we will learn in this project a step-by-step approach for a case of acute dyspnea by advanced critical care ultrasound. I was asked to see a 68-year-old female patient in case of hypertension, morbidly obese, who recently complained of shortness of breath. Her dyspnea was gradually progressive over 2 weeks, previous 2 weeks, and at the time of examination, she was dyspneic at rest. Journal examination, febrile, heart rate 120 per minute AF, blood pressure 160/70, respiratory rate 34 per minute, heart examination, tachycardia AF, chest scattered with basal crackle. I saw very recently this patient. We started advanced critical care ultrasound for dyspnea. For those who need certification in advanced critical care echo, whether American or European, you need to follow this protocol, please. You need to do all this examination to get your diagnosis and to complete your logbook in a nice way. First, you will assess the inferior vena cava. Elephant inferior vena cava, maximum diameter is 3.6 centimeter, mildly collapsing. Really, if you see this type of inferior vena cava in a dyspneic patient, you should think of obstructive or cardiogenic causes of dyspnea. Please go to the heart. You will find your answer in the heart, because all cardiogenic causes and obstructive causes, you can get it from proper advanced critical care echo. Left ventricle, you need to exclude left ventricle weakness, left ventricle failure as a cause of this acute dyspnea. The patient really was morbid obese. There is no too much views available. We did this 5-chamber view. From the first impression, you will see the left ventricle is small and contracting, but the left atrial is markedly dilated. Right side is not ballooning and no significant pericardial effusion. You can, but now let us step by step. I will look only for the left ventricle. I believe it's contracting properly. It's almost kissing. I am sorry for this hazy picture, but the patient was morbidly obese. Okay. The recent guideline for American Society of Echocardiography and European Association of Cardiovascular Imaging talk about biplane method of disc, modified Simpson method, as a gold standard in assessment of the left ventricle for chamber quantification. We did biplane modified Simpson method for our patient. This is the end diastolic for chamber view, and this is the end systolic. You see, patient is contracting well. And we did 2-chamber view, end diastolic volume and end systolic volume of the 2-chamber view. As you see, the software will give you very important fact here. Will give you the ejection fraction biplane in both 4-chamber view and 2-chamber view. It is 62%, great, and will give you the stroke volume, which is 75 milli, great for the patient. Okay, so left ventricle, ejection fraction, and stroke volume is normal, is good. And to confirm the efficiency of the left ventricle, we did the stroke volume. We measure the stroke volume by the Doppler methods. Very easy. We are talking about advanced critical care echo. You will measure the left ventricular outflow tract diameter, and you will measure the LVOT, left ventricular outflow tract VTI, velocity time integral, the blood flow in the left ventricular outflow tract. You will put the pulsed wave Doppler sample volume here half centimeter above the aortic valve to see the closing click, to be sure you are in a proper place. You are not in the aortic valve, you are in the tract, okay? And after tracing the LVOT VTI and measuring the diameter of LVOT, very easy, stroke volume equal the square of the diameter left ventricular flow tract diameter square multiplied by 0.785 multiplied by LVOT VTI, you will get the stroke volume. We did for our patient this. We measure the left ventricular flow tract diameter and we get really, because the patient is fibrillating, you will expect variability in the LVOT VTI. It will not be the same. So we get a 5 waves, 5 LVOT VTI, the average of the 5, and we did the stroke volume. It was 65. It was also normal. So our patient has normal stroke volume and normal ejection fraction. Left ventricle is doing well. Left ventricle ejection fraction stroke volume is normal. Very important question from advanced critical care ultrasound point of view. Is a normal ejection fraction stroke volume exclude a cardiac congestion, exclude a left side cause as a cause of dyspnea? Please, from the advanced critical care ultrasound point of view, before excluding the left ventricle as a cause of acute dyspnea, you need to ask 3 questions. Ask yourself 3 questions. First, what about the longitudinal function of the left ventricle? In left ventricle, there is mostly radial fibers, almost 90%, which will cause squeezing of the left ventricle. And this will determine mainly ejection fraction. The main determinant of the ejection fraction is this squeezing function of the left ventricle due to radial fibers. But also, there is longitudinal fibers, which will be affected in case of subendocardial ischemia or fibrosis or strain of the left ventricle. The average quantity of the radial fibers to the longitudinal fibers, it's almost 10 to 1. This is done in the experiment in the pig, in the canine. But please, before excluding the left ventricular dysfunction as a cause of acute dyspnea, you need to assess this longitudinal function of the left ventricle. Up and down movement of the left ventricle. We did by tissue Doppler. We did tissue Doppler here in the septal mitral valve annulus and assess the S prime, which is the surrogate of the longitudinal function of the left ventricle. The average of this S prime, because it's variable because of AF, it was 6 centimeter per second, which is low. So our patient has longitudinal functional dysfunction, longitudinal function of left ventricle abnormality, despite this ejection fraction. And this may happen early in strain of the subendocardial fibers. Second, what about the left-sided valve? You can see left ventricle contracting very well, but the patient has acute pulmonary edema due to acute left side valve lesion. So you need to exclude left side valve lesion before releasing the left ventricle as a cause and excluding. We look for the mitral valve. You see mild mitral regurg cannot explain this dyspnea, severe dyspnea. We trace the aortic valve systolic flow. We trace it. And as you see here, because I am putting the continuous wave Doppler in the aortic valve, I will see both opening click and the closing click. So that means I am in the valve. But to detect LVOT VTI, I need to see only closing click. But here I am see both closing and opening and closing click. I trace the aortic valve, maximum velocity 203. and the mean gradient 8.8. It's not significant to cause acute dyspnea. So I excluded the left side valve lesion as a cause of acute dyspnea. Third, and really very important, what about diastolic function and the left atrial pressure? It's very important to assess properly the diastolic function in a patient with acute dyspnea, because diastolic failure is a cause of acute pulmonary edema. Because the patient has AF, according to the American Society of Echocardiography and the European Association of Cardiovascular Imaging, I need to assess two things: the average of the E wave velocity over average of the tissue E prime velocity. If more than or equal to 11, it's going with left ventricular dysfunction, diastolic dysfunction, and increased left atrial pressure. And I will assess the deceleration time of the mitral valve flow. If less than or equal 160 milliseconds, that means there is diastolic dysfunction. In our patient, the deceleration time, the average of deceleration, I did deceleration time several times. In our patient, the average E over E prime, it was 12, above 11, that means going with diastolic dysfunction and increased left atrial pressure. And the average deceleration time of several beats, it was less than 160. You see 90, 92, 13, 133, 104, all less than 160. So our patient for sure has left ventricular dysfunction, diastolic dysfunction, and increased left atrial pressure. And I measure the left atrial volume, it's markedly increased, 125 milli. What about other causes to exclude in dyspnea? Right ventricle. According to the new guidelines of American Society of Cardiography and the European Association of Cardiovascular Imaging, the diameter should be more than, basal diameter should be more than 4.1 to be dilated. In our patient, it's 2.5. Right side is not dilated, and the TAPSE should be less than 1.7 to be impaired. Right ventricle, here is TAPSE 1.77, and the interdiastolic right ventricular diameter is normal. That means no right side dilatation and ballooning, which may cause acute dyspnea in case of pulmonary embolism. You can exclude that in our patient who has severe dyspnea. And what about another obstructive causes, pericardial effusion? In our patient, it was very mild pericardial effusion to cause this acute dyspnea. To sum up of our advanced critical care ultrasound for dyspnea in this patient: normal size and function of right ventricle, mild pericardial effusion, no significant left side valve lesion, normal ejection fraction and stroke volume, but impaired longitudinal function of the left ventricle, and diastolic dysfunction with increased left atrial pressure. What is the most cause of this scenario? Hypertension, and you can get an idea about the hypertension as a cause if you see hypertrophied walls, here inferior wall, here is the septum. As you see, you even go beyond the acute dyspnea. You know the cause of this acute, the pathology, the pathogenesis of this acute dyspnea, and the cause behind this pathogenesis. What is the remaining? You need to see the pulmonary congestion to be sure that it is the full scenario and the complete pictures of the left side diastolic failure with pulmonary edema. We saw this in lung ultrasound because it's seen pleura, no subpleural consolidation, and B-line all over. As you see, advanced critical care ultrasound is a magic, and this is the way you need to follow if you need to do your logbook in advanced critical care ultrasound certification. You need to go in this sequence in cases of acute respiratory failure. As you see, you are going beyond the pathogenesis and to go to diagnose the cause, and you see yourself the pulmonary congestion. And this is the integrative approach between echo and lung ultrasound. And as you see, there is a lot of B lines. And thank you for watching. To see more of these cases, please join us on our next online critical care ultrasound from basic to advanced, due in the next May. Will be live and recorded lectures. Really, you will see hundreds of real cases, and you will see how to approach the case of shock, the case of dyspnea, the case of acute renal failure, almost all varieties of critical care ultrasound. This is the link of our online course. This is the link for our course. I believe it will be the great course. We did it last year, and we received very good reputation from the candidate who joined us. And I will give this link in the first comment and in the description of the video, and hope to see you all, and hope you enjoy our advanced critical care echo approach for acute dyspnea. Bye bye.